Okay, good afternoon, everyone, and I just wanted to welcome you all to our webinar today. Our topic today is psychotropic medications. Our presenter is Don Mitkus. We'll let you know that our session today is being recorded, and it will be archived on our website at www.prevention.org under the Student Assistance Center and in the resources section of our website there. In addition, I wanted to let everyone who's on the call today know that the Student Assistance Center has joined the Twitter sphere, and you can follow us on Twitter at our Twitter handle. Our Twitter handle is capital S, capital A, capital C, enter, PF. So that is SA Center PF. On Twitter, you can follow us. We will tweet and retweet some interesting things that we see on the things that we're following as well. We'll announce upcoming trainings, webinars, etc. on Twitter, and also look forward to engaging in depth with all of you in terms of discussions, questions that you may have as you follow us on Twitter. So we look forward to serving you in that new and unique technological way. And we hope that you enjoy the presentation today. I'm going to turn it over to Don. And Don, I'm giving you control of the webinar now.
Thanks, Dale. Okay, thank you, Dale. Again, my name is Don Mitkus. I'm a consultant with the Student Assistance Center at Prevention First. As you can see, I'm a licensed clinical professional counselor and a certified alcohol and drug counselor. And our topic today is psychotropic medications. In particular, we're going to be focusing on the medications that are prescribed for children and adolescents. So we'll be skipping over the anti-dementia medication and all that other stuff that isn't necessarily pertinent to the populations you work with. So, as by way of introduction, this is a deep topic. There is a lot of information about the different types of psychotropic medications that children and adolescents are prescribed to deal with a myriad of behavioral health related symptoms. So we're going to delve into the more common ones, the ones that you are more likely to see. We'll touch upon some of the medications that you might run into, just so if at the very least you could recognize it for what type of medication it might be, and dig a little deeper in on your own in regards to those. So just by way of introduction, psychotropic medications are meant to help individuals manage their psychiatric symptoms. Make no mistake, there is no magic cure. There is no antibiotic. There is no medical treatment that will cure someone. There's no medicine that will cure someone of a psychiatric condition. What they are meant to do is to help someone manage the symptoms that are commonly associated with a particular condition. So when a doctor is choosing medication, the algorithms they use are first and foremost based on diagnosis. Not every medication treats every type of condition. So the diagnosis is the first big clue that a physician has in choosing an appropriate medication. And some of the things that they take a look at when they're prescribing medication includes benefit versus side effects. A lot of these medications have a range of side effects, and we'll talk a little bit about those by class of medication. Some of them have issues with toxicity. How easy are they to use? What kind of interactions might you experience with current medications that are currently on, or in consideration of what combination of medications you might use to treat a particular condition. Those are the things that a physician is going to look at when making a choice regarding recommending or prescribing a particular medication. Other things they'll be taking a look at is what what types of medications have they tried before, and what types of medications have other family members been on and responded to. There is something of a genetic correlation between whether if a family, particularly a parent or a sibling, has responded or had an adverse response to a particular medication. That's a pretty good indicator to that physician to either move towards or avoid a particular med. Other considerations: starting, stopping, changing medication is how much time do you have, how significant are the symptoms, because that does play a role in what medication is chosen to start treatment of the symptoms. Some medications take a much longer time to reach a therapeutic level. If you're changing a medication, considerations on taking them off one medication at the same time you're ramping up another, because again, medications take a little bit of time. Depending on the medication, it could be a few days to several weeks before they reach a therapeutic level. So they're and as you're taking someone off a medication, there is some medications have something of a withdrawal effect. So they have to be cautious on how they bring someone down off one medication and bring them up if they're doing a medication change. Now, it's not uncommon for someone to be on more, particularly if their symptoms are significant or complex, to have someone on more than one medication at once. It's not uncommon for 2, sometimes even 3 or 4 medications to be prescribed to manage an array of symptoms. So if there's a medication change that needs to happen because their symptoms aren't being managed, then the rule is to change one at a time. You don't want to do complex changes. You don't want to take 1 or 2. You don't want to take 2 or 3 medications down and bring 2 or 3 up, because you're not controlling for which one might be the one that's not being effective. So, and then the response rate is really dependent on the right diagnosis. Are you targeting the right symptoms? If they've had treatment failures, these are indicative of whether or not someone's going to be compliant or respond to the medication. If they've gone through several courses of different medications, one of the things to look at is whether or not they are responding to the medication or being compliant with it. So the FDA controls all these medications. There's been a lot of attention over the past 10 years on how the FDA has handled psychotropic medications. There's certainly advantages to having an approval process for a medication or a new medication, because the FDA requires that it be very thoroughly studied, from initial trials to animal trials to human trials, before it's allowed to be unleashed on the general population. So unfortunately, a study population versus the real world isn't always directly analogous, and the pharmaceutical companies are multi-billion-dollar corporations that have an agenda and many dollars invested in research and development on these meds. So they have a very highly vested interest in getting these drugs to market to recoup their research and development costs. So they put a lot of pressure to get these medications pushed through. Now, each medication is indicated for treating a particular condition or particular symptoms. With psychotropic medications, you do see quite a bit of what's called off-label using and dosing, which means that a doctor may prescribe a medication in a dosage or not specifically to the letter of the FDA has approved it for, because it has shown to be effective in particular cases. Just to give you an example, Prozac, which is an antidepressant, we'll talk about that in a second, is often used in the treatment of bulimia in high doses. It's shown to be effective to curb the impulse to purge. But it's again at a dosage that's higher than recommended. Normal recommended dosage for Prozac is 20 to 40 milligrams, and normally the dosages are 80 to 100 milligrams to be effective for treating bulimia in this way. It's an off-label usage. The FDA wrote a position paper on this in 1982 that said it's if it's found to be therapeutic, they will allow off-label use, but they strongly urge caution. FDA also requires that a side effect listing, no matter how many people a side effect, how small a percentage of side effect is seen in, it must be reported to the general public as a potential side effect, either common, uncommon, or rare in occurrence. And that's led to things like black box warnings. So one of the major concerns that came up with antidepressant medications in adolescents is the possibility that will induce suicidal thoughts when first taking it. Now, there's a lot of debate about that particular black box warning. It scared a lot of people away from taking antidepressant medications and scared a lot of doctors away from prescribing it, particularly primary care or pediatricians, family care doctors. Now, 90% of the psychotropic medication that is prescribed today is prescribed by primary care, family practice, and pediatricians. So most of these medications are being prescribed by physicians that have kind of really a minimal amount of training when it comes to psychopharmacology. So they're very risk averse when it comes to these sorts of medications. Now the flip side of that is when the black box warning came out on antidepressants in a somewhat short order, we saw a rise in the frequency and percentage of suicide attempts and suicide completions amongst teens and adolescents. Now, while there's not been a study to prove that corollary, it is significant and it's something to pay attention to. So these are the different, I know this seems like an overwhelming list, and we will be paying more particular attention to the antidepressants, the stimulants, and the anti-anxiety medications, because those are the ones that you're going to be more freely running into, and we'll be touching on these others. So SSRI antidepressants, one of the more commonly prescribed medications, just less frequently prescribed than anti-anxiety medications. Annual sales of $12 billion. Millions, hundreds of millions of people have been prescribed antidepressant medications. The first one that was introduced was Prozac in 1988. Now, SSRIs are selective serotonin reuptake inhibitors. Now, what that means is that serotonin is a neurotransmitter. It's a brain chemical that helps regulate your mood. How good you feel. When your serotonin levels are low, you feel down, depressed, tired. When your serotonin levels are up, you feel good, great, happy, energetic. And what the thing about these brain chemicals, these neurotransmitters, is your body has a hard time producing them. So what it does is it likes to reuse them. So when it releases serotonin into the brain synapse to send a signal along to the next brain cell saying, hey, it's time to be happy, once its job is done, the brain cell will reabsorb that serotonin molecule for use again later. Now what SSRIs do is it goes and it sits on those reuptake pumps, those things that will reabsorb the serotonin and what that into the brain cell for later use. And what that does is it keeps the serotonin out there in the synapse, activating those receptor sites on the brain cells, the happy receptors, and it keeps it out there doing its job longer. So that's in essence that's what SSRIs do. Now, the SSRI antidepressants are, particularly Prozac, have an effect on serotonin, but there are others that have effects on other types of neurotransmitters to a greater or lesser degree. And we'll talk a little bit about those. But the major ones, again, that have been introduced, Prozac in 88, Zoloft, Paxil, and Luvox a few years after that, Celexa in 98, generic Prozac was introduced in 2001, Lexapro in 2002, and in 2006 the STAR-D trial results were published. Now what that was a massive study on the effective treatments of depression, and it included a large amount of research on the effectiveness on antidepressant medications in SSRIs on how it studied how effective they were in treating depressive symptoms. And what was found in the STAR-D trials was that that a combination of medication, SSRIs, or other one of the atypical antidepressants, in combination with counseling or therapy together, was the most effective way to reduce depressive symptoms and to increase quality of life for those that suffer from depression. So again, we talked about the mechanism of action. So it inhibits the reuptake of serotonin at higher doses. Again, they affect other receptors and other neurotransmitters. The thing about these medications is that they take a while to get to a therapeutic dose, a therapeutic level in the system, to act long enough for someone to be able to feel its effects. Now, normally with pretty much all of the SSRIs, per individual does not start to feel the effects of them, even the effects, minor effects, for 2 weeks after taking it regularly. You start to see some major improvements, major symptom reduction at 4 weeks, and right around 8 weeks is where someone will reach their maximum therapeutic benefit from that particular dosage. So it's the problem with something taking so long to take effect is compliance. People, when they feel bad, they want to feel better, and they would like to feel better now. So it's an issue when you start taking medication. You start to feel the side effects, because you do start to accumulate the side effects fairly quickly. The chances that the side effect we mentioned earlier about the activating suicidal thoughts or ideations is usually seen within the first few days of starting one of these types of medications. So you might start to see side effects right away, but not benefits. So it turns into a compliance issue. So if you have a student that is starting one of these medications, ideally you want to encourage them to stick with it, even if they're frustrated and not feeling much symptom relief, to stick with it until it starts to kick in and take effect, and to reinforce when they do start to report that they are getting a benefit from these medications. So serotonin receptors are not just in the brain, they are throughout the body, which is impactful when you have a depression that also carries physical discomfort. Physical pain is also can be a part of a depressive disorder. And SSRIs in particular can be helpful in treating depression that has a chronic pain component to it. So all of these medications are FDA approved to treat depression. So there are some that are also used off-label to treat other issues. So the two depressive disorders that these medications are used to treat are major depressive disorder and dysthymia. And dysthymia is a low-grade depression that lasts a long time. You have to suffer from these symptoms for a couple of years to be diagnosed with dysthymia. So it's not something you typically see with children and adolescents, but major depressive disorder you do. So there's some of these medications are approved by the FDA to treat other issues. Some have off-label use. I think, like I mentioned earlier, the chronic pain syndrome, seasonal affective disorders. These medications can be helpful in treating that, but it's not an FDA approved usage of those medications. So some in particular, such as Luvox, are approved to treat issues like generalized anxiety disorder, OCD. They're found to be helpful with those particular conditions because of the effect they have on other neurotransmitters in the brain. Okay, so the half-life. What half-life is the half-life of medication is how long it takes your body to break down half of the dose that you've put into it and eliminate it from the body. The quicker something is eliminated, the upshot here is that the shorter a half-life something has, the more likely someone is to have a side effect or an unpleasant experience should they miss a dosage of their medication. So fluoxetine, which is Prozac, has a long half-life. So that's a medication that's good for those that are more prone to missed doses, such as a child or an adolescent. So Prozac tends to be more of a go-to for children and adolescents when it comes to depression. Some side effects of SSRI antidepressants, which become compliance issues for people taking these medications. For adolescents in particular, decreased sex drive, impaired sexual function, which don't necessarily resolve completely over time or after discontinuing the medication. Nausea, diarrhea, anorexia, vomiting tend to may occur in some folks and be worse at higher doses, but these do tend to resolve after the medication stops. Weight gain is a big concern, especially in particular with adolescent girls taking antidepressant medications. Some others that can range: headaches, dizziness, anxiety, rash, insomnia, and so on and so on. If you read any of the inserts in any of these medications, or take a look at the physician desk reference, which is the 6-inch thick book that has information on all prescribed medications, all medications that are prescribed. The side effects list tend to be pretty extensive, but the concern with side effects is it tends to affect or impact those that are they're taking them as far as their desire to take them. It becomes a compliance issue when they experience side effects. The side effects are bad enough, they may just stop taking the medication, even if it's giving them symptom relief from their depressive disorder. So these specific ones, Celexa, which is one of the newer antidepressant SSRI medications, has few interactions. It's highly specific to serotonin and its typical side effects. Lexapro, which is also which essentially is a cleaned up molecule of Celexa. So it's one half of the molecule, which tends to have pure side effects because it's a cleaner molecule. And then Prozac, it can have some pretty significant drug-to-drug interaction. It stays in the system quite a while, which is good for those that might be prone to missed doses. But again, you have to be careful if someone is taking more than one medication, how it might react with the Prozac. Fluvoxamine, which is Luvox, as I mentioned before, can also be used to treat OCD, obsessive compulsive disorder. Paxil tends to have a higher rate of weight gain as a side effect. Has a shorter half-life, so if you miss a dose, it's the uncomfortable feelings and experiences that come along with withdrawal from an SSRI come on quicker with this particular medication, and it interacts with quite a few other medications. It is pretty effective in treating generalized anxiety disorder as well as depression. Zoloft is, next to Prozac, is probably the second most frequently prescribed antidepressant medication. Drug-to-drug interactions tend to be less than Paxil or Luvox, and it has a greater range of dosing options than the other medications do, so they can pinpoint an effective dosage a little bit more specifically. Again, with higher dosage of these medication, more side effects start to emerge. So some of the more newer medications that are not or less specific to the serotonin system or affect serotonin a little differently than the SSRIs do, include medications such as trazodone, which is also helpful for sleep. Wellbutrin. Wellbutrin is somewhat unique because it works more on norepinephrine, and was also packaged as Zyban. If you recall, Zyban is a medication that helped with stopping smoking. The thing about the SNRIs, the selective norepinephrine reuptake inhibitors, such as Wellbutrin, is it had to be cautious because it lowers people's seizure thresholds. So one of the potential side effects is seizure activity. So if someone is prone to seizures or has a family history of seizure disorders, it's not a medication they should be taking, because their chances of having a seizure are higher because they're on these types of medications. So all have been, again, been approved to treat depression. The SNRIs have been shown to be a little bit more effective in treating neuropathic or nerve pathway pain, treating nicotine addiction. Often these are the medications that are being prescribed alongside an SSRI, so they will work with each other, and they're hitting a broader range of neural transmitters, hopefully being more effective in helping someone manage their depressive symptoms. There's some evidence that they reduce the sexual side effects of the SSRI. Insomnia tends to, trazodone is one of the things that's often frequently prescribed for those that have depression that causes significant sleep disturbance. And the SNRIs tend not to be associated with sexual dysfunction, as are the SSRIs. So Effexor. Effexor is another medication that's been approved to not only treat depression but also generalized anxiety and social anxiety disorders. Minimal interactions with other medications, but there are side effects with missed dosage. These are medications that should not be, any of these, SSRIs or SNRIs, none of these medications should be stopped suddenly. There can be a very uncomfortable, not necessarily medically dangerous, but extraordinarily physically and psychiatrically uncomfortable withdrawal that comes along with these. Cymbalta, which is probably one of the more widely commercialized medications. There's frequent commercials on the TV for Cymbalta that treats the neuropathic pain that sometimes comes along with the depressive disorder. Again, Wellbutrin, again, we talked about the treating smoking addiction, and this is a very low interaction, drug-drug interaction with other medications, so it's pretty safe to prescribe with other medications, except in the case where the other medication also reduces someone's seizure threshold. Remeron, it has to be very, very closely watched. It's not very frequently prescribed anymore, but it is on occasion, because it also it's an agonist for the alpha-2 receptor site for norepinephrine, so it can be effective for those that are not responding to other medications, but sedation and weight gain is pretty significant with Remeron. Cerazone, rarely used. It can really mess up the liver. It can be very, very effective in treating depression, but you've got to be very, very cautious and watch liver enzyme levels fairly frequently, or else it can really do some significant damage. Trazodone, again, used for insomnia. And it tends to drop blood pressure, so if someone has low blood pressure to begin with, it's not necessarily a frontline medication, but can be useful in treating the insomnia that comes along with the depressive disorder. The tricyclics, these are the grandfathers of antidepressant medications. Rarely will you run into these, particularly with adolescents, but on occasion you will, especially if they're being treated by a physician that is, lack of a better term, old school. These are medications that are, if SSRIs and SNRIs are scalpels, these are shotguns. They affect wide ranges of neurotransmitters in the brain. They're effective, but they have some very significant side effects, and they really have to be watched carefully, because they can do some damage if they're not monitored through blood levels. And multiple significant interactions with other medications. So it's there can be significant weight gain, significant sedation, blood pressure dropping from sitting to standing, cardiac issues. These are drugs that if you overdose on them, it will kill you. And they're being given to depressed patients. So if someone attempts to overdose on their medication in order to attempt suicide, they're more likely to be successful and complete the suicide if they're on a tricyclic antidepressant. The note here about bipolar disorder: someone with bipolar should not be given an antidepressant medication, because it can, and particularly with the tricyclic antidepressants, these medications can trigger a manic episode. So it's actually an indicator and should be paid attention to when someone starts one of these medications. If they start to exhibit manic symptoms, hyperactive, grandiose thoughts, risk-taking, not sleeping, that could be an indicator that the person is actually suffering from a bipolar disorder, not a depressive disorder. So that's one of the things to look out for as someone starts antidepressant medications. It's more profound drop into a manic episode if someone starts a tricyclic antidepressant. Okay, moving on. Probably one of the most common medications you're going to run into are the stimulant medications that are used to treat attention deficit hyperactivity disorder and attention deficit disorder. Despite what might be popular belief about these medications, out of all the psychotropic medications, stimulants probably have the least undesirable side effect profile, least undesirable side effect profile. So they're pretty safe medications in general, although they are abused fairly frequently for the stimulant effects, or it's not uncommon for people to share their medication or sell their medication. And these are meds that are pretty commonly being abused in high school and college settings for performance enhancement, test preparation, finals. It's pretty widespread, unfortunately. So Ritalin's been around for quite a long time now. Despite there's a range of medication labels. Essentially, stimulant, the ADHD medications, come down to two types of medications: Ritalin and dextrine, and they're all the medications are derivatives or different formulations of these two chemicals. So about 10% of 10-year-old boys in the United States are on stimulants. About 2.5 million kids are on stimulants. There was a recent FDA warning about increased cardiovascular risk for patients on stimulants, and that's any stimulant medication is going to increase cardiovascular risk. You're stimulating the systems in the body, and that includes the heart. And you work the heart harder. If there's any sort of heart defect or a cardiac issue present, the chances of turning into a cardiac incident are higher when you introduce a stimulant medication into the mix. So, well, I said two things, two medications, but there's actually kind of on the outside a third medication that's being prescribed for ADHD, and it's called Strattera. It's not a stimulant, though. It's It's an SNRI. It's a selective norepinephrine reuptake inhibitor, and like the antidepressant medications, Strattera takes 2 to 4 weeks to start to have an impact on the symptoms that someone's experiencing, so it takes time. The thing about the stimulant medications is that they the impact, the symptom reduction is immediate. You don't have to wait 2 to 4 weeks for these drugs to start working. If they're going to work, they're going to work right away. Two others that are less frequently used are catapressant and Cylert. Catapressant in particular is more being used for those that are dealing with more complex attention deficit and co-occurring Tourette's. Cylert is somewhat old school, and it's rarely used because of its impact on the liver. So dexedrine. Dexedrine and Ritalin, these are pretty much all stimulant medications come down to dexedrine or versions of dexedrine or Ritalin. Dexedrines are your Adderalls, your Adderall XLs, your Ritalin LA. What the pharmaceutical companies have done is package these medications in different forms in order to make them longer or shorter acting. Ritalin, typically you're going to get about 2 to 4 hours of effect out of. So those that are on regular Ritalin, they're typically having to go to the nurse or the office midday to get their second dose of Ritalin, and they're getting home from school and taking a dose to kind of get them through homework, and then it wears off. Now, they've done some things, including it's called encapsulating Ritalin for a long-acting version. So the way it's doses inside the pills are encapsulated doses of the medication that over time throughout the day the stomach acid breaks down these little capsules within the larger pill and releasing doses over a longer period of time. So it's you tend to get a 6 to 8, more like 6-7 hours out of a long-acting Ritalin LA or an Adderall XR, because that's also how they work with that particular medication. Than you would the 2 to 4 out of a regular type of Ritalin dosage. Another form is a pill that essentially is a hollow capsule with multiple chambers that the capsule, when it's swallowed, is one of the chambers is actually it reacts to the stomach acid and starts pushing the medication out from the other end, essentially, much like a plunger. So it will release medication over the course of 8 to 12 hours. So you get some fairly long-acting, continuous dosing of medication throughout the day to help maintain attention and reduce hyperactivity through this form of delivery system. So essentially the medications are the same. The molecules, the dexedrine molecules, the Ritalin molecules are the same despite the type of medication. It's just how the medication is delivered into the body is what determines what the different medications are. So it's many kids report that the feelings of hyperactivity and distractedness are uncomfortable for them. Many kids are taken off their medications for breaks or over the summer, and frankly, these are fairly safe medications if taken correctly. So it's many adolescents have reported that they feel better if they're on medication year-round. And as they take these medications, as their symptoms are controlled, they're in a better position to learn ways to cope with their inactivity, their inattention, and their hyperactivity. Where over time, the ideal is to taper off or discontinue these medications. One of our physicians who does a lot of presentations on medications is a diagnosed attention deficit guy himself who's unmedicated, because he's over time, over years of being on medication, has learned ways to compensate for his symptoms, and isn't on them any longer. Very interesting guy. Anyways, Provigil is another ADHD drug that's typically used for sleepiness to keep people up who treats narcolepsy, and its use for ADHD is being investigated. Mood stabilizers. These are medications that are used to treat those that suffer from bipolar disorder, those that have significant cycles that will cycle through depression and hypomania or mania. Many of these medications are used to treat seizure disorders. So and they've been found to be effective in treating bipolar as well. So there's some other medications, and we'll touch on those that are used to treat bipolar, usually used in combination with a mood stabilizer. And there's some debates. Some of these medications are more effective at treating the acute manic state, which is, again, grandiose, tangential thoughts, can't sleep, risk-taking, grandiose, versus prophylactically taking it, which is meant to prevent the cycling from occurring, versus treating the depressive stage or the depressive part of the cycle. The first medications that were used, the first one really was lithium, which is a salt. It was recognized as being effective in treating mania back in 1949, and it was used to treat those that had bipolar disorder through the 50s. The problem is that lithium can be pretty toxic and has to be monitored very, very closely. Again, as through the 60s and 70s, other medications were discovered to be effective in treating instability of mood. So lithium's the only mood stabilizer that's not used to treat seizure disorders as well. Effectiveness is pretty significant, 70% response rate, which is pretty high for these types of medication. It's shown to reduce suicidality. For those that rapidly cycle, meaning they go between mania and depression very quickly, they can cycle daily or several times a day. It's not quite as effective and it takes time to build up in the system to a therapeutic level. So, and as they get up to a therapeutic level, they're having to have frequent blood draws to monitor the lithium level in their bloodstream, again, to monitor when it's getting up to a therapeutic level, but also to make sure that it's not getting too high, because when lithium levels get high, it's again, it can be toxic. It's excreted through the kidneys as opposed to the liver, which most medications are excreted through the liver. So side effects: tremor, weight gain, nausea, increased thirst. It is a salt, so it dehydrates. As if someone reaches a more toxic level in their system, the tremors can get significant. They can become unstable, confused, vomiting, diarrhea. If someone starts restricting their fluid intake, they can't, or in particularly hot weather, the toxicity risk becomes higher. And over time, if it's not monitored closely, it can cause kidney and thyroid dysfunction. So those are creatinine, BUN, and TSH are monitored closely to make sure that it's not impacting it negatively. And for some reason, women are at much greater risk for the lithium to impact their thyroid than men are. Tegretol, which is another mood stabilizer, treats acute mania, bipolar. It's shown to be more effective for those that rapidly cycle. Again, it's something that has to be monitored closely because it can have adverse effects on the body and become toxic. The dosage has to be closely monitored and blood levels have to be monitored because there's an increased, whereas most medications have a half-life and are eliminated at a fairly constant rate. Tegretol is unique in that it increases the half-life, gets shorter the longer that you take it. So the dose has to be monitored and adjusted over time. But it can cause sedation, nausea, rashes, can affect red blood cells and white blood cells. It's possible that there's liver function abnormalities, but it's not that often. There are some folks that will metabolize Tegretol in such a way that it creates a metabolite or it breaks down into metabolites, and one of those metabolites in some people that can be produced is toxic, and should be checked for on a regular basis to make sure that it's not metabolizing into this toxic metabolite. Pardon me. So Depakote is probably the most widely prescribed medication for the treatment of bipolar disorder because it can be dosed rapidly to bring someone out of an acute manic state. It's more effective than lithium treating rapid cycling folks who have bipolar, and it has been used in other psychiatric disorders, psychotic disorders that have aggressive or impulsive features. It can be it's used to treat migraines preventatively, and it also is used to treat seizures or seizure disorders. So there's some suggestion that it be supplemented with other medications to reduce its side effects, which can include nausea, weight gain, liver dysfunction, decreased platelets, pancreatitis. It's something, again, these medications can be toxic if over longer periods of time or in high enough dosage, so they have to be monitored very closely, which again is a compliance issue. As people experience these side effects, they may not want to take it, especially if they're entering into a manic phase in their cycle where they're feeling kind of good. Compliance, folks that have bipolar disorder have notorious compliance issues when it comes to taking their medication. But without their medication, those with bipolar disorder tend to have symptoms that make it extraordinarily difficult for them to function from day to day. So the benefit of medication usually does outweigh the side effects or the drawbacks of taking it, even though these side effects seem pretty significant, and they are. They do allow folks with bipolar disorder to have a quality of life and to engage in regular life activities. So some newer mood stabilizers were developed in the 90s. Lamictal, minimally sedating unlike other mood stabilizers, more effective with those that are whose bipolar leans more towards depression, it's not something that should be taken in conjunction with Depakote because it has an interaction where it increases Depakote increases the levels of this medication in the system, and Tegretol tends to decrease these levels in the system. So there are some medications that shouldn't be taken together, and the Lamictal and Depakote, or Lamictal and Tegretol are two such cases. Trileptal more effective when used with other mood stabilizers. You often see this matched up with Depakote. And Topamax is, there's some debate over how effective it is as a mood stabilizer, even though it's used fairly frequently in conjunction with other mood stabilizers. And it's for those that have body image or concerns about weight gain, and do their research, and folks do their research, will prefer to be on Topamax because they tend to see weight loss as opposed to weight gain. Keppra and Zonagon are relatively new, and there's some debate whether or not how effective they are in treating bipolar, although it's being used off-label to do that. And then Symbyax, which is a combination of olanzapine and Prozac, has been approved recently to treat bipolar. Antipsychotics. The thing about antipsychotic medications, it's not just for psychosis anymore. Antipsychotic medications are also being used with mood stabilizers, and being used to in combination with mood stabilizers to treat instability of mood, such as bipolar or disorders that have a high impulsivity or aggressive features to them, in combination fairly effectively. So these are these medications are different from some of the older antipsychotics, such as your Haldols, that were, again, if these are the scalpels to the shotguns that were the older antipsychotics. They have much, their side effect profile is less significant than the older antipsychotics, and are more likely to be adhered to or be compliant with. So let's see. And one of the risks of the older antipsychotic medication is what's called EPS, or extrapyramidal symptoms. So which can be permanent. These are things that are jerkiness of movement, unsteadiness of gait, and these medication can induce, the older medications are more likely to induce these EPS symptoms that can last long after the medication or permanently after the medication has been discontinued. The thing about antipsychotics is there's a significant risk of obesity, diabetes, and lipid abnormalities. And the risks kind of go up. As you can see, clozapine is the highest, followed by olanzapine, quetiapine, risperidone are somewhere in the middle, and ziprasidone or aripiprazole have the least risk of obesity, diabetes, and lipid abnormalities, although that still is a potential side effect. The EPS, or movement disorders, neuromuscular symptoms, they can still occur with these medications, but it's much less than with your typical or older antipsychotic medications. Aripiprazole or Abilify, it's fairly effective for treating psychotic symptoms and disorders. It's often being used as a booster for antidepressant medications. So a small dose, typically 2 milligrams of Abilify in conjunction with a antidepressant is, for some folks, is more effective than taking the antidepressant alone. Clozaril is very, very effective in treating psychosis, but the side effect profile is pretty high. The thing about folks with psychotic disorders is there's a high incidence of nicotine addiction or smoking, and smoking reduces the levels of Clozaril in the system, as it does with Zyprexa. Again, these are helpful in treating the positive aspects, positive meaning additive side symptoms of psychosis, which are your the hallucinations, the delusions, those sorts of things. Some are more effective, like the Abilify, at treating the negative symptoms, the withdrawal, the isolation, isolativeness, the kind of the withdrawing aspect of psychosis. Seroquel, it's commonly used as a sedating agent. Is more for those that have more aggressive or are more highly irritable in their disorders. Risperdal, one of the Angiodan, both have a dosing, the ability to be dosed by injection, where rather than having to take a pill every day, they can take an injection that will last for a month. So it's pretty significant in terms of being able to get people to comply with their medication if they only have to have a once-a-month injection versus taking a pill one or more times per day. Benzodiazepines, these are the anti-anxiety medications, and the ones that these without a benzodiazepines are the most highly prescribed and highly abused medications out there today. They have sedative hypnotic effects and are effective in treating acute anxiety. But since the introduction of SSRIs in the 90s, they're not as frequently prescribed for long-term treatment of anxiety because the SSRIs can prophylactically treat the anxiety disorders. Looks like we just have a couple of minutes left. So the thing about benzodiazepines is they have a very high abuse and addiction potential, and can have some long-term effects after someone discontinues their use if they're using it for more than a few months. So along with alcohol withdrawal, benzodiazepine withdrawal is the one type of drug withdrawal that can actually be fatal. So it's we urge a lot of caution when it comes to the use of benzodiazepines, especially children and adolescents. You tend not to see as much of the use of the Valiums or the Ativans or the Xanaxes, and you see more use of the Klonopin, which is a lower potency type of benzodiazepine. So let's see here. So this just goes over the different types of benzos and how long they last. Some of them are pretty short-acting, like Xanax. The thing is that with short-acting medications is if you use them more frequently, when you stop them, your chances of withdrawal are higher. Those that last longer, you will still experience withdrawal, but it tends to be delayed by a few days, and the withdrawal tends to be more intense. So with that, that covers the major classifications of psychotropic medications. If anyone has any questions, be happy to take them at this time.
And I'll open the mics for everyone so you can ask any questions that you have. I have a question here, Don. It says many of their ADHD students are being changed to intuitive. Can you talk about this new trend?
Intuitive is a relatively new medication, and again, it's a method of delivery system. Intuitive is the medication I mentioned that has the plunger effect. That's Intuitive. So it's the same type of medication. It's just how it's delivered into the system. In some ways, it's considered to be safer. But the thing is because it can't really be crushed up very effectively as you can with a Ritalin or an Adderall tablet, because you got this kind of gel stuff that really kind of messes it up if you crush the tablet for abusing it. So it's in some ways it's a safer medication to prescribe.
Okay. Any other questions? Hearing none, I'd like to thank you for attending, and I'd also like to mention a couple of other things. Of course, you're welcome to join us for any of our upcoming webinars. We will be having a new webinar that was just added. That'll be next Thursday from 1:30 to 2:30, and that's on SAP and technology. Belleville West has designed a technology system to monitor and collect their data and referral and monitoring information. So they'll be presenting to us on that technological system that they use. So we invite you and your tech group at your schools to join us on that webinar to learn more about that system and how it might be a useful system for you in your SAP work. And as well, we are doing a couple of one-day trainings on SAP working with community partners. One of those will be in Maryville, Illinois on April 9th, and the other one will be in Vernon Hills, Illinois, up in Lake County. That one is scheduled for May 9th, so both of those are on our website as well for you to register for and come out, and we look forward to seeing you and having you with us on our webinars and at our trainings. Once again, don't forget to follow us on Twitter. That's capital S, capital A, capital C, enter, capital P, capital F is our Twitter handle. That's the SAC Center PF on Twitter. So we look forward to providing continued service to you and information on topics of interest to you in the future. Thank you all for attending. Have a great day.